اوكي. لكن ميرسي لكل الاطباء يلي انضموا لنا. ثانك يو لبروفيسور ميرنا واكد، شيف دو ديبارتمون دو لا ميديسين انترن بمستشفى سان جورج الاشرفيه، وحضرتك نمولوج. مشكوره لاعطائك من وقتنا اليوم لحتى نحكي اكثر بموضوع سرطان الرئة. القصص يلي كميدسان دو فامي والجي بيز مفترض يكونوا عم ينتبهوا لها بمعايناتهم للمرضى، لحتى ننتبه دائما لموضوع الكشف المبكر عن سرطان الرئة. أكيد بحب أشكر شركة أسترازينيكا لدعمها الدايم لنا كجمعية بربارة النصار لنشر التوعية، والكلام لحضرتك.
مرحبا والمساء الخير. أنا بدي أشكر الأسوسياسيون بربارة نصار على دايما هالجهد الفظيع يلي هو التوعية للمساعدة لكل أنواع الكانسر. وأنا أكيد بهمني حسب اختصاصي نحكي عن سرطان الرئة لون كانسر. بشكر كمان أسترازينيكا لأنه تعاوني معهم على كل الأصعدة بمستوى علمي كتير عالي. فاليوم بتحبوا أحكي بالعربي بالإنجليزي؟ شايفين السلايدز تبعولي؟
يس، إذا
كتير.
بتحبي يو كان فيك توسعيها إذا بتحبي.
فوالا. أوكي.
بص.
أوكي. لكن اليوم بدنا نحكي عن شغلة كتير مهمة، هي time to act against lung cancer. And how would we do that? By increasing diagnosis. And I'm a very important advocate for screening. I'm a very much in favor of screening of lung cancer. Why? Because it's very important to go and see. Sorry. Okay. اجتماع اليوم ما في شيء ظابط. سلايداتي. Sorry. Okay. So lung cancer, we talk about it when we have abnormal cells developing in one or both lung. They grow so quickly that the body immune system cannot keep up with these cancer. The abnormal cells can form tumors that keep the lungs from working. And if left untreated, the cancer can spread to nearby lymph nodes and other parts of the body. So for normal cells to be transformed into a cancerous cell, we have different alteration of on the genetic level, and this is very much required. And we will see that these alteration, genomic alteration, with risk factors, environmental risk factors, and habits of smoking can really interact to give us, to give the patient a cancer, a lung cancer. Interestingly enough, إذا بنطلع على الأرقام بالعالم بنلاقي إنه في عنا أعلى نسبة كانسر هي لون كانسر في بالعالم. بال 2022 هذه الدراسة 2,480,000 مصاب بسرطان الرئة. وإذا بدنا نقارن هالإصابة بالعالم للإصابات الثانية بالسرطان الثدي أو الأمعاء أو البروستات، في أعلى نسبة هي للون كانسر، بيجي دغري من بعدها 12.4% بالبريست كانسر، كولوريكتور هي 9.6%. وإذا بدنا نشوف الفرق، إذا بدنا نقسم حسب إذا عند الرجال والنساء، بيبقى لون كانسر هو نسبته الأعلى عند الرجال في عنا 15.2% مقارنة بالبروستات اللي بيجي دغري من بعده 14.2%. بينما عند المرأة البريست كانسر بعده بالأول بالطليعة ويجي من بعدها لون كانسر، وعم بتزيد نسب اللون كانسر. وهيدي الدراسة أو الإحصاءات تبع بالعالم 2022. شو هن risk factors for developing lung cancer؟ أكيد مثل ما بتعرفوا كلكم smoking, all types of smoking. وبحب كتير شدد على شغلة تانية، هي second and third hand smoking. Very important exposure. هي بطليعة الأسباب لللون كانسر بيجي كتير بعدين من بعدها بمراتب مش دغري حواليها، بس لازم نعرف إنه في exposure مثل الأسبستس، في عنا اللي بيشتغلوا بالinhaled chemicals مثل الأرسنك، بريليوم، كاديوم. في أنواع أعمال يعني أو مهن بتخلي الإنسان يكون معرض لهذا النوع من الريسك فاكتورز. في كمان dietary supplements بيتا كاروتين، arsenic من drinking water، أكيد radiation therapy to lungs previously for any other reason، air pollution، heavy traffic roads اللي هي من الأسباب المهمة، and family history of lung cancers. بس برجع بجدد smoking all types are the most important risk factor، و second and third hand smoking هن بالطليعة. هلا وقت نحكي عن الدخان، وخاصة مش من الأطباء بس، وقت عم نحكي عن الدخان ومضار التدخين للناس اللي منهم أطباء، دايما بس بيفوكسوا على سرطان الرئة لون كانسر. مثل ما شايفين على الشمال من سلايد هن لون كانسر أهم وحدة، لكن منه بس لون كانسر، في أنواع سرطانات تانية بالأسوفاجس، باول، بانكرياس، ستومك، لارynx، كدني and so on. بعدين ضرر هو مش بس كانسر مثل على اليمين، في عنا كل أنواع الكانسر ممكن تكون مرتبطة ومن وراها التدخين، لكن في كمان أضرار تانية للصحة مثل stroke, blindness, gum infection, heart disease, pneumonias, peripheral artery disease, chronic lung disease like COPD and so on. So smoking is definitely damaging the lungs, and the risk of developing tobacco-related cancer depends on three factors. أول شيء قديش average tobacco consumption، قديش duration of smoking، واللي هي هيدول two criteria بفوتوا بالback year evolution أو evaluation of smoking and the risk for developing any disease related to smoking but cancer specifically. بس بدي شدد على a very new, let's say, risk factor or dependent factor for developing lung cancer، هي age of smoking initiation. أي عمر بلش الإنسان بالتدخين. It's becoming definitely one of the major criteria to assess the risk to develop a related cancer to tobacco. And as you see on the left, أكيد, you know that there are 4,000 chemicals in the gases that are from the tobacco smoke, like arsenic, acetone, lead, formaldehyde, and so on. And on the right, you see that smoking cessation, it's never too late to quit smoking, and it's really this definitely decreased the cumulative risk to develop cancer from smoking. The never smokers are definitely the less having risk. Those who stop at very early, at age 30, definitely have a very low cumulative risk, but definitely when you see that the age of stopping is higher, the cumulative risk is still high, and especially in those who continue to smoke, where the cumulative risk is reaching more than 15% to develop lung cancer. So just again, to come back to this new, very important notion, the age of starting smoking, why is it the strongest risk factor, apart from the number of cigarettes and the duration? because when we are adolescent and before the early 20s, if we start like 15 and 18 years old, these immature airways are definitely exposed to carcinogens, and this will lead to greater DNA damage, more mutation, higher chance of malignant transformation. And the earlier we start, and dramatically, this will definitely increase the long time exposure. And those who start earlier, they always have smoke more years, like more years of duration of smoking. And this has not only an additive effect, it has a multiple effect or multiplication effect. So earlier initiation also predict heavier dependence. The younger we start, the more we have addiction to nicotine, and it's hard to quit. And we have this modern cohort studies showing that starting before age 15, it will increase the lung cancer risk from 3 to 4-fold more than someone who started in their 20s and with the same back here. Okay, so definitely this is a new notion that we will add to the number of cigarettes we smoke and duration of smoking. Having said that, we cannot not ignore also vaping, which is a new trend, because people think that it is less damage to the lungs. But we need to say that we know till now that it's not completely harmless, because in the vaping smoke, it contains several carcinogenic compounds like particulate matter, heavy metal, formaldehyde, and they really definitely contributing to air pollution. And also in the batteries and the metal coated wires and the battery acid, the heavy metals that are really in the constitution of the vaping system. And we have improper disposable of pods or cartridges and e-liquid or liquid containers. All these will increase the environmental toxicants in air, water, and soil, and could increase lung cancer risk. We don't have enough data till now. However, we need to be very cautious about it. What are the symptoms of lung cancer? The more when it is asymptomatic, it is definitely you can have a lung cancer without symptoms, and in the presence of symptoms, the stage of the disease unfortunately is already advanced. Appetite loss, very let's say sensitive to the appetite loss, the fatigue, the weight loss, and a cough which is persistent, not really responding to any treatment, any breathlessness, dyspnea, cough with hemoptysis, and any pleuritic chest pain, and so on, and any infection that is not responding to medical treatment have a high index of suspicion for cancer. But now here we are interested in the value of detection early of lung cancer, of the screening. So we don't want to wait for the symptoms. So the lung cancer screening test is something important, but we need to consider something or a test that has some, let's say, very good values. Like it definitely will change the outcomes. It must be scientifically validated and not being an added risk for the patient. Having a low risk, it can be reproducible, accessible, and cost effective. So the best way to prevent lung cancer is definitely by never smoking or stopping as early as possible. But lung cancer screening is definitely not a substitute for smoking cessation. I have a lot of patients بيجوا بيقولوا لي اوكي انا بدخن لكن بدي اعمل سكان كل سنه او كل 6 اشهر لحتى الحق. This is definitely not something that really can be replacing smoking cessation. So why would it be effective if we have a screening program for lung cancer? Because lung cancer, as we saw in the epidemiologic statistics in the world, has a huge prevalence. It's high morbidity and mortality. It is linked to risk factors. We know these risk factors, and this will allow targeting this disease. And unfortunately, it has a very lengthy preclinical phase. يعني what the cancer بيطلع عندنا symptoms, it is rather not too late, but it is an advanced stage. Therapy is more effective in early stage disease. قد ما فينا نعمل detection lung cancer بالأول, the best, we have a good therapy for it. And there is evidence for cost effectiveness. So أكيد ideal screening test لازم يكون عنده high sensitivity and يكون عندنا high true positive. High specificity يعني we don't have it is specific, not a false positive, safe, acceptable, low cost, and decreasing mortality and or improve quality of life. Okay, how to diagnose lung cancer? X-ray by incidental finding. It could be during an X-ray done for something else, for a pre-op, let's say. But the CT scan now is the exam of choice for screening for lung nodules, and it is a low-dose CT scan. So when we have an evidence of something going wrong and a suspicious lung cancer, we diagnose it by two ways. Bronchoscopy, if the tumor is proximal, meaning it is really in the around the main bronchus, accessible in a segmental and main bronchus, we can use the bronchoscope to have a tissue diagnosis, and transparietal biopsy when it is peripheral, it's not accessible by a bronchoscopy. The tumors need to be accessible through CT scan guided biopsy. It's important to have an histology because now with the pathology and molecular biology studies, we definitely can offer the patient a very good and adequate treatment. So what do we have as type of lung cancer? في عنا اثنين, فينا small cell and non-small cell. Small cell is 15% of all lung cancer in the United States, whereas the non-small cell, he 85% of all lung cancer in the US. Why are it's very important to say small cell and non-small cell, because small cells by definition are aggressive tumor. They are not surgical. They are treated by chemoradiotherapy, and they definitely harbor a rapid initial response, but unfortunately we have frequent relapses and progression of the disease. Whereas non-small cell lung cancer, which is the most frequent one, is 85% of all cancers in the US, all lung cancers in the US, but they are divided and subtypes in adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. The highest percentage is for adeno-CA. These are the new trend because back to 30 years and 40 years ago, squamous cell was the most prevalent, but now it's adeno-CA. So non-small cell lung cancer is very important to identify it because now we have, from the biologic and molecular biology, we have definitely interesting subdivision inside the adeno-CA and the squamous cell lung cancer. It's a subdivision by any mutation that can be a target for treatment, or any chain or receptors identified that can be targeted, because the treatment of lung cancer definitely made a huge progress and very important novelties in the treatment. So when I say small cell non-small cell، صراحة ما بعرف. وقت يسألوني مرضاي شو بيقصدوا، بيسألوني انت ولا ذكر. I don't know what does it mean صراحة. إذا حدا عنده جواب أكيد يساعدنا. So بس example، لأنه بنسمع كتير فيهم وبتسمعوا كتير فيهم شو ال EGFR والALK اللي هن أكتر شيء بنفتش عليهم بالأدينوكارسينوما. EGFR هي epidermal growth factor receptor. It's a receptor on the cell surface of the cell that tells the cell to grow. يعني هذا mechanism that is responsible of growing the cell. When it goes wrong معناتها في mutation تغيير at the level of the chromosome, a deletion that makes the receptor overactive ما بقى بيوقف, constantly sending growth signal للcell اللي هي growing into a tumor. So إذا بدنا نعمل مقاربة هي مثل كأنه دعسة الفريم سوري الأكسلريتر يعني البنزين نازلة وما عم نقدر نطلعها, ما في شيء عم يطلعها. So there is completely an overreacting and an abnormal signal to the cell. The treatment هن thyrokinase inhibitors, EGFR thyrokinase inhibitor مثل ozimatinib that turn off بسكت هال overactivated signaling. This is a huge progress in treatment of the lung cancer. Another one which is very also frequent the adenocarcinoma type هي الانابلاستيك lymphoma kinase اللي هو gene inside the cell that normally كمان should be quiet in lung cells, but what goes wrong, a gene fusion, any abnormality at that level creates a new abnormal protein that drives continuous tumor growth. كمان a wrong engine installed in the car and running non-stop إذا بدنا نعمل مقاربة, and the ALK inhibitors like those who are cited here, which are cited here, can be also an option. And this is where I will just stop concerning the specificity of receptor and anti-receptors in lung cancer. So it's very important when we have an evidence of a lung cancer to do a cancer staging, because it changes completely the narrative of the disease and the prognosis. And two very important things to be done: PET scan that will give you any idea about any avid focus other than the lung cancer, like the mediastinum, like any metastasis in the lung, or any distant metastasis extrathoracic. But we need also to always complete the cancer staging by a brain MRI, because the PET scan is not sensitive for this area of the body. So staging is really important, because staging is the key to have a stratification of prognosis, an idea of the survival on the patient. So it goes from the stage A, 1A and B, to the stage 4A and 4B. Without going into the very important details in this case, I will just tell you that why do we have these subclassification? Because the 1 centimeter increase in the size of a tumor can change completely the staging and completely the prognosis. This is why you see that we have a huge interval of 5-year survival in the stage 1. So it goes from 68 to 92%. And stage 2 is 53 to 60% 5-year survival percentage. Stage 4 is really the dismal part, from 0 to 10%. But what I want really to show you that when we diagnose the cancer, the most frequently we diagnose at 40%, in a very high percentage, they are at stage 4. And 25 to 26% stage 1 or 25 or stage 3, and stage 2 is 9%. So the diagnosis late is very important. It's really very, very much impacting the survival and the prognosis, whereas screening and prevention will definitely help us go and detect the patient at an earlier stage. So prevention is stop smoking. Okay, psychological support. We can use a lot of things, nicotine replacement treatment. We can have a remote help, self-support tool. And I will be very, very much, I will insist on this, is the electronic cigarette. If you are not experts to use it as a tool for smoking cessation, please don't use it. And don't tell the patient that could be a modality for stopping smoking. So when we do a program of lung cancer screening and detection, we need really to assess some outcomes to evaluate how much is it effective to be implemented. So it will definitely we need an information about how much detection rates we have for this cancer, what are the stages when detected, survival, is it impacted, disease-specific mortality and overall mortality. And this is where some things are not definitely understood, or there are some bias in it. So some will say, well, you are doing a low dose CT scan to your smoking patients, but what about the potential harms of this screening? This is, I think, valid because a screening can detect benign abnormalities, and we can go into a spiral of investigation in a patient. منهم ضروريات. We have radiation risks. It is definitely something, a burden for the patient because it's a prolonged follow-up. And again, we have also a risk of overdiagnosis. So the problem is, just to say, this is one of the main, let's say, bias we have when we talk about detection and screening of lung cancer, what we call the lead time bias. So when you screen a patient, the survival is confounded by lead time. Say, if you have an earlier detection, it increases the survival, even if death is not delayed. يعني here we have symptoms, and we have the symptoms, and we have a diagnosis here. And so the lead time to death is considered the survival. So a patient has been symptomatic here, diagnosed here, and he survived this period of time until death. If we just detect him earlier, he's asymptomatic, we are just having screening, and here we diagnose the cancer. So survival, the death is the same moment. However, the survivor seems definitely increased in this case. So this is what we call the bias of lead time. I will not go more in this, but it's just something we need to be aware of when we analyze the result of the screening of lung cancer. So the problem also with survival, this is what I said, the length time bias, the length time of those growing cancer. We have indolent cancer that have a longer biological lifespan, يعني they are slowly growing. في عنا aggressive cancer. So if we compare these aggressive cancer and indolent cancer concerning the screening. So when we do the program of screening, if we're dealing with an aggressive cancer, we can diagnose like 1 or 2 out of 8 of these. We can really have a screening of let's say in an early stage, 1 or 2 out of 8. Whereas in those indolent, they have a longer biologic lifespan. We have 3 to 4 out of 8. So one word about overdiagnosis, we need to know it also. We are doctors. We need to be aware of some of the roadblocks or some of the side effects or of overdiagnosis. We can have falsely increased sensitivity of the test, falsely increase the positive predictive value of the test, falsely increasing the incidence, improve the stage distribution, falsely improve case survival. So, and overdiagnosis does not decrease population mortality. So we need to know the limitation of these programs. However, doesn't mean that it is not efficient. So if we want to go through some of the biggest programs of screening of lung cancer, this is the National Lung Screening Trial in the US, where they started by eligibility criteria, age 55 to 74 years, current or former smoker of more or equal to 30 pack years smoking history, former smoking, but within last 15 years. More than this, they are not in the program. No history of lung cancer at the moment of enrollment, no treatment for or evidence of any other cancer within the last 5 years. So in this case, the low-dose CT was compared to chest radiography, and in the comparison, the low-dose CT scan detected definitely more lung cancer. And compared to the X-ray, the difference or the relative risk of detecting by low-dose CT compared to chest radiography was 1.13. So in this national program also, that what was very interesting is to look at the detection of stages. How was it compared to chest X-ray? And definitely in the low-dose CT scan in yellow, at total all stages, the CT was superior to chest X-ray. But what was interesting, and I think if we just distribute all these by stages, and we see the performance of low-dose CT scan compared to X-ray, and this is where the value of screening is really emerged. Why? Because we have a superiority and the statistically significant difference بالstage 1A. ليش؟ لأنه this is where it is interesting to look at the screening, because we are detecting more cancer in the very early stage than in this X-ray. Whereas in the stage 4, unfortunately, X-ray is enough because we can detect a lot of things, pleural effusion, metastasis, and so on. And the other stages that are definitely even almost equal. But interestingly enough, and statistically very interesting, is the big difference when we detect a cancer in low dose with low dose CT scan. Is the mortality impacted with the low dose CT scan when we compare in years of randomization? At the start, we don't see a difference. However, they really split here, and the cumulative number of lung cancer deaths is higher in those with chest that has been diagnosed with chest radiography, and low dose CT, meaning it's really detecting an earlier stage. So the screen positivity rate was very interesting in this study, in this national lung screening test. It was a cumulative of 24% positive. And what was interesting that the nodule of more than 4 millimeter or other finding potentially related to lung cancer was considered a positive screening. When we had, they've done screening 1, screening 2, screening 3. After 3 rounds, it was negative. It is definitely a negative by protocol. So lung cancer screening program needs to be integrated in any approach. However, to be really efficient and reliable, we need to have a selection, a very well done selecting criteria for eligible patient. We need to have a quality of imaging and image interpretation, مش حيلا, and management of those screened. When we detect them very early, we need to have a system. We have divisions of oncology, pulmonary, family, and GPs that know their material, on what to do, what to refer, and exactly the importance of effectiveness of smoking cessation intervention, especially when we have very small nodules that can be definitely, let's say, a good trigger for smoking cessation intervention. So the one of the biggest, let's say, recommendation or guidelines and decision made that made the screening of lung cancer with low dose CT scan was in the U.S. In the Centers for Medicare Medicaid Services, that they determined that the evidence is really enough to add lung cancer screening, counseling, shared decision-making visit, and use annual screening for lung cancer with low-dose computed tomography. So that was definitely important. They really thought about what would be the eligibility for including the age. It would be also very important to have absence of signs or symptoms of lung cancer. Why? Because it's not anymore screening. When the patient is symptomatic, we need to have the regular CT scan or whatever else. And also evaluate the cigarette smoking back years and the year of starting and the number of years since quitting, etc. So another, let's say, part of prevention services task force in the U.S. that really were advocating lung cancer screening, and there is a little bit difference between some of the protocols concerning the ages interval. Some will go for 55, others will say 50 to 80, others will say 50 to 75, but and also they will lower the threshold of back years like 20, not 30. And but what is important is that quitting within the past 15 years and more, we don't do any more lung screening for lung cancer. So it is a screening every year. a patient مثل ما قلنا موقف من أكثر من 15 سنة ما عاد نعمل screening. And stop screening once a person has a health problem that definitely limits life expectancy for another reason than lung cancer and no ability to have lung surgery. مثل ما قلت في كتير task forces, في Canadian task forces on prevention healthcare. How are the recommendation? They are changing, but مثل ما قلت في differences صغار. يعني مثلا Canadian in 55 to 74 years, 30 back year, and they insist also on the value of an annually screening test, but also they go to say, well, there is a potential for screening relating harms, and we need to always weigh advantages over risks. What I want you to go with as an important message, if you don't want to go into the different, let's say, guidelines and so on, but probably the main message of the low-dose CT scan screening for lung cancer would be that we are taking our patient from a stage 4, and we are really shifting a stage to something better with an survival rate, which is definitely higher and higher and higher. From 7% overall survivor in 4B to 82% in the stage of 1A. I think this is the most important, I think, slide from all this presentation, because this is where you can have a clear message in your mind, embedded in your way of thinking. So I'm not changing the word. I'm not promising anything like impossible, but I'm helping my smoker to move from a very dismal stage to a curable stage. Again, other like the National Comprehensive Cancer Network, I've just put these slides just to show you that it can be some differences in the age group, in the threshold of back years of smoking cigarettes. However, the bulk is the same, meaning you need the risk exposure, cigarette smoking, exposure to radon, occupational exposure, disease history like COPD and so on. And don't take those low risk like age less than 50, less than 20 pack year history of smoking. In this case, lung cancer screening is not recommended. Why did I put the Taiwan experience in screening of lung cancer? Because I have a lot of experiences, but I just retained the Taiwan experience, and you will see why. Because, and interestingly enough, that if we compare the lung screening result in Asia, it's an expert consensus report in 2023. It was in the ESMO Congress in Barcelona in 2024. So just if we want to compare the result of the screening in Europe, North America versus Asia, you see that you have a lot of, a lot of colors. But in the very dark blue, we have lung cancer cases. You have in age standardized incidence rate. You have in pink age standardized mortality rate, and in light blue the lung cancer deaths. So in Asia, the necessity to go for screening and the result of screening is not yet there, because lung cancer deaths is still the lung cancer cases and lung cancer deaths are more and more than age standardized mortality rate. However, in other countries, you see that the age standardized mortality is higher than lung cancer case, which is like an index of success of the prevention and detection of lung cancer. And again, I won't go into details, but this is an article in 2022 in the Journal of Thoracic Oncology from the Taiwanese also, where they are showing how they shifted from in 10 years from 2009 to 2019 in shifting and increasing the 5-year survival rate, and in the non-small lung cancer 5-year survival from like a very low, like 15% 5-year survival rate, to a higher, more than 50%, 53.4%. And that was also due to the fact that they used as a screening program. And again, you see also that in stage 1 and in the last part of their program, the last one from 2018 and above, you have definitely, interestingly, increasing in the number of stage 1 detected earlier. And this is, again, the shift of staging that improves lung cancer survival in these studies, the same one. And I kept the last one just because we have always we can do مثل ما نقولوا l'avocat du diable is the detection or the low dose CT scan screening not possible in never smokers, and is it valid in with or without family history of lung cancer? And interestingly enough, because Taiwan, they have a high prevalence of lung cancer in non-smoker, and very interesting. So I will not go into the details. I'll just say, like here, the editorial is interesting. Never say no to never smokers. So never say no low dose CT scan to never smokers. But this is very specific to these countries, and especially Taiwan. So the overall conclusion of this Taiwanese study, that the low dose CT scan screening in never smoker with additional risk factors, first degree family history, would be interesting in this population to detect high proportion of early stage potentially curable lung cancer. we cannot recommend it as a systematic in non-smokers, but definitely we need to be aware that with additional risk factors like environmental exposure or a family history of cancer could be an indication, but individualized. You cannot really be a whole program and recommendation. We're not yet there. It's not established that we have a mortality benefit. So I think that to end this presentation, screening program should be targeted to the specific context of the epidemiology of each country, especially when we're dealing with a non-smoker patient. And I want to thank you. And I hope that this was something that interests you. And so if any question, any comment, I'm ready to answer.
Thank you دكتور بروفيسور واكد يعني اسم الله عليك. آه، اوكي رح نبلش بالاسئله. شذى عثمان.
Hello. Olshi, thank you for this amazing presentation, Dr. Mirna Waked.
Thank you. Thank you.
As a first semester medical student, I'm curious about how do doctors balance the risk of overdiagnosing lung cancer in screening with the benefit of catching cancer early?
Yeah. Like, definitely, as I said before, you need to have to balance the side effects from radiation and everything. You need to have a very well established program, very well balanced. You need to have very important criteria of eligible patient. You need to have very highly knowledgeable experts in radiology and in HIDA, and you need to be in a context where you have different expertise like oncologists, pulmonologists, radiologists, interventional radiologists to be able to take care of these persons. وتوقفي إذا فينا نقول مش الهدر بس تعملي بالانس بين side effects من سكرينينج هيك على البجنب مثل ما بنقول نحن بالعربي هيك المشبرحين.
Okay, thank you a lot.
Thank you.
محمد مسايكي.
مسايكي.
نعم، يعطيكم العافية على المحاضرة القيمة جدا.
شكرا.
الله يبارك فيكي. بس سؤال هلا في عنا بالكانسر في شيء اسمه جريد وفي ستيج.
نعم.
What is the difference between the grade and the stage of the cancer?
اوكي هلا the grade هي اذا بدك الجريدنج هي كل specifically when واصل التيومر. اوكي وين واصله شو الدايمنشن تبعها. ستيجينج هو صار اصعب، صار كتير صعبوها وبس عملوا لها سب ديفيجن لانه بين انه بين ال1A وال1B في فرق بالسايز تبع التيومر وبال شو اسمه الميدياستينال نودز هايلر نودز ايها مأخوذه زيت الميله من التيومر أو تاني ميلة من التيومر. So it's been كتير staging أو grading تقريبا عم نستعملهم بذات الطريقة. بس كتير صايرين مفصلين قد ما صار في فرق ب1 سنتي. إذا زادت سايز تبع التيومر 1 سنتي فيها تفرق البروجنوزيس.
Yes. Thanks so much.
Thank you.
Thank you.
حبيب.
Hello, Dr. حسكيال. كيفك؟
Thank you, Doctor.
الو
ميرسي كثير
كيفك؟
لك على هالبرزنتيشن، وبدي اتشكر الاورجنايزرز كمان
شكرا
على
شكرا.
مجهودهم بالتنظيم. السؤال يلي بدي اطرحه، مثل ما عم نعمل كامبينز تو سكرين فور بريست كانسر، كامبينز تو سكرين فور بروستيت كانسر، كان في كامبينز عن السي او بي دي، كامبينز عن الازمه تريتمنت، ليش ما بنعمل كامبينز عن السموكينج وسكرينينج فور لانج كانسر كمان بذات الطريقه؟ لانه قد ايه بتوفر علينا ايرلي ديسكفري، وقد ايه بتوفر علينا كوست بالتريتمنت.
كتير بشكرك على هيدا التعليق، وأنا بشكر من جديد بربارا نصار اسوسيشن، لأنه هن عطول، هن السباقين، وهن عطول زنبرك بهيك حالات. معك كل الحق. ليك ما في شك أنه وقع كل الأزمات اللي دخل فيها لبنان كان لها تأثير كتير كبير على العصب العلمي والعصب الفكري، إذا بدك. هيدا تعليق كتير شخصي، وبشكرك على هيدا التعليق، لأنه كتير تأثرنا في كتير أشياء، رجعنا فيها صراحة لورا، ولأسباب عديدة، منها الأسباب الاقتصادية. لأنه برنامج اللانج سكرينينج برنامج منه أكيد بيوفر، بس ما في رؤية، ما في فيجن لهلا. نحن مشغولين بقضايا حياتية، إذا بدنا نقول بدائية شوي. كتير رجعنا لورا، حتى كسوسيتي سيانتيفيك كنا نعمل كتير اشياء. بس بعتقد وضع البلد فرض علينا، والبروجرام اللانج كانسر سكرينينج هو برنامج كتير بده درس من الناحية إذا بدك الرونتابيليتي، وقت بنحكي عن مستشفى، عن سنتر، عن أونكولوجي. بس ديفنتلي هيدا مفروض نعمله في إنه يروق الحال، وبمساعدة باربارا نصار and أسترازينيكا أو غيره، والنقابة.
ثانك يو.
ميرسي لك.
Any other questions? بالتعليقات. اوكي. دونك لكن نحن فينا نختم بروفيسور واكد. شكرا على هالمحاضرة القيمة. أكيد كمان بوجه الشكر لأسترازينيكا. وبرجع بقول يعني أكيد جمعية بربارا نصار دايما حاضرة لتنظيم الندوات التوعوية، إن كان للعموم بشكل عام، وإن شاء الله كمان كل الاختصاصات بنكون عم نتوجه للجي بيز وغيرهم. وأكيد بدي أتشكر كمان نائبة الأطباء لأنه وجهت الدعوة كمان، وبتصور الجمعية العلمية كمان تبع الأطباء. بشكركم جميعا لانضمامكم، وإن شاء الله فيكم ترجعوا تشوفوا الندوة اللي رح نرجع ننزلها على السوشيال ميديا.
Thank
شكرا.
you.
ثانك يو.
Thank you. Thank you كتير كتير كتير. شكرا. أنا كتير كتير كنت سعيدة بهاللقاء، وإن شاء الله ما بكون آخر لقاء.
إذا الله رد أكيد.
Thank you.